Today, we are going to be talking about preventing and reducing catheter-associated urinary tract infections, or CAUTIs. This is presented to you by Jessica Lasuski, Kelsey English, Linda Brodsky, Lindsay Huffman, and Jamie Wilson. The nursing problem. In an effort to reduce and prevent catheter-associated urinary tract infections, we researched and evaluated the use of chlorhexidine for patient bathing and compared that to regular soap and water use in Foley catheter care to determine if it reduced catheter-associated UTIs in the adult intensive care unit population. The significance of the problem. Catheter-associated urinary tract infections are the most common healthcare-associated infection at 34% of total infections. Healthcare-associated infections can lead to an increased hospital length of stay, higher death rates, and substantially higher costs. Healthcare-associated infections can lead to long-term disabilities. Healthcare-associated infections can cost hospitals an estimated of $9.8 billion annually to treat. Catheter-associated urinary tract infections can add an estimated $896 to a patient's hospital bill. 12 to 16% of the adult inpatient population has an indwelling catheter during their hospital stay. 3 to 7% of those patients have an increased risk of catheter-associated urinary tract infection each day they have that indwelling catheter. The literature summary. There was a study by Fink that revealed that the use of an antiseptic, such as chlorhexidine or CHG, was used only 44% of the time prior to the insertion of indwelling catheters, whereas soap and water was used over half of the time in the current nursing practice. There was also a study by Noto that revealed that repeated use of chlorhexidine or CHG can lead to antimicrobial resistance. The Centers for Disease Control and Prevention, or CDC, found that routine use of decolonization using topical antimicrobials should be limited to high prevalence outbreaks in special care units. There was also a study that said there's an increasing clinical use of CHG. It raises the concern that organisms may develop resistance to the antiseptic and to other antimicrobials with repeated exposure. Researchers have found evidence suggesting an association between minimum concentrations of CHG and resistance in coagulase-negative staphylococci, gram-negative bacilli, and a selection of MRSA isolates in hospital ICUs. According to an article by Denny and Monroe, chlorhexidine can cause minor reactions when a patient comes in contact with it, such as skin irritation, itching, or burning. Chlorhexidine can also cause more irreversible damage, such as corneal injuries and corneal scarring with inadvertent exposure during CHG bathing. There's a study by Rupp that states there is no significance between the use of chlorhexidine bathing and the reduction of catheter-associated urinary tract infections when compared with non-antimicrobial bathing. We need to implement a plan. The first part of the plan is to engage and educate. We need to organize a healthcare team committed to patient safety control practices. We need to incorporate tools to better identify and address key challenges, for example, the CAUTI Guide to Patient Safety. We also need to identify mentors to educate healthcare team on all facets of Foley catheter use, including patient education, sterile technique for insertion, maintenance, and removal protocols. We need to execute the A, B, C, D, E of prevention of catheter-associated urinary tract infections as outlined by the Joint Commission based on evidence-based practice research. A, adherence to general infection control principles, such as hand hygiene, surveillance and feedback, aseptic insertion, proper maintenance, and education is very important. B, bladder ultrasound may avoid indwelling catheterization. C, condom catheters or other alternatives to an indwelling catheter, such as intermittent catheterization, should be considered in appropriate patients. D, do not use the indwelling catheter unless you must. E, early removal of the catheter using a reminder or nurse-initiated removal protocol appears warranted. We need to evaluate. Approximately 30% of hospitals do not have an established surveillance system for monitoring urinary tract infection rates. More than 50% of hospitals do not have a system for monitoring which patients have urinary catheters. More than 70% do not routinely monitor the duration and discontinuation of urinary catheters. Only 9% of hospitals use a urinary catheter stop order or a reminder. Approximately 14% use condom catheters in appropriate male patients. And only about 30% use a portable bladder ultrasound scanner for determining post-void residual. The barriers to preventing CODIs is a lack of support from leadership. It was determined that physicians were not aware of nursing practices in CODI prevention. Information or educational posters are usually posted in nurse break rooms where physicians are not likely to see it, and medical directors did not communicate information to other physicians. Evidence suggests better engaging physicians and the healthcare team in patient safety initiatives. There's a lack of organizational infrastructure. Hospitals often have higher patient-to-staff ratios, which can lead to the staff feeling that they do not have time to perform the catheter care needed to prevent catheter-associated urinary tract infections. Hospitals also lack the resources to audit the catheter-associated urinary tract infection prevention bundles, making it difficult to know if the staff are performing the bundles or performing them correctly. There's also a lack of communication. Communication is a big part of patient care. When there's a lack of communication, patient care can be lost. Healthcare team members may not adequately communicate that a patient has not received catheter care, resulting in a greater chance of a catheter-associated urinary tract infection. There's a lack of education. Nurses need to be educated on the importance of catheter-associated urinary tract infection prevention. There may be a lack of education on catheter-associated urinary tract infection prevention measures and the facility's protocols. Hospitals also need to educate on the proper use and placement of catheters. Elements of practice that need to be changed. There needs to be a more standardized catheter-associated urinary tract infection prevention bundles and consensus throughout the hospital on what the specific actions in the bundles should be. Physician education on standard CODI prevention practices. There needs to be more intensive education regarding catheter-associated urinary tract infection prevention, including the importance of bundles. There needs to be nurse autonomy on prompt removal of the catheter. There also needs to be training and utilization of catheter-associated urinary tract infection nurse ambassadors to round and educate the staff and patients on CODI prevention. we have learned that chlorhexidine does not help prevent catheter-associated urinary tract infections, but that proper CAUTI prevention measures and bundles do prevent them.